introduce myself. My name is Nasser El-Ghandour, President of the Egyptian Society of Neurological Surgeons. Let me welcome all the participants. Let me thank Professor Sakai for accepting our invitation to be our speaker in this webinar number 4 among the series of webinars organized by the Egyptian Society of Neurological Surgeons. Let me give the speech to Professor Dr. Tamer Hassan from Alexandria University. He is the moderator of this session. Thank you very much.
Dr. Tamer.
دكتور تامر دكتور تامر دكتور تامر دكتور تامر unmute yourself please. دكتور تامر دكتور تامر
Good morning.
せっかく作ったのに。
Dr. Tamer, you are with us now?
Yes. Please, please don't unmute me again.
Okay. Please, you can start the webinar now, Dr. Tamer.
だって俺コロラド行ってあれ行ったもん。だから俺もうすでにダイヤモンドだもん。
Hello, Sakai Sensei.
Yes.
Hello, good morning. Hello,
I'm
how are
Sakai.
you?
Hello.
How are you? So we have the pleasure to be with Professor Sakai today. He is the director of the Department of Neurosurgery at the Comprehensive Stroke Center in Kobe. He is also the president of this year Japanese Society of Intravascular Neurosurgery. And next year, I hope there will be a meeting on the WFITN. So he is also the president. So it's a big honor to have you with us today. So he will start his talk of about aneurysm coiling, the updates and what's new in this field. Thank you. Please start.
Okay. So thank you, Tamao. And so I'm Nobuki Sakai. So let's start. Please hear. But the sound is not so clear. Please, I apologize for you. So I'd like to start now. This切りたいな。ほっとかなしゃあないな。これが映ってるから。これ俺の。あ、そう。こうして。停止か。ちゃんと言ってるよ。掘ったら。聞いた。これが下手っていう。はい、乾杯。成功。サクセス。これも何事も経験。強気のそう。戦紛争。試験の専門家で。
Dr. Sakai, there is no sound with the presentation. Sakai Sensei.
Dr. Tamer, he is not speaking.
ما فيش صوت، انا مش سامع صوت برضو.
while the mic is open.
يا دكتور مايكل، انا شايف فيه راو سامعينه. هل ده من مننا احنا ولا في حد تاني فاتح؟ يعني خلي الميكروفونات بتوع السبيكر والبانل بس، الباقي يتاكد ان هو ميوت.
حصل يا دكتور ما عدا البانلست بس هو في دوشه حوالين
لا يا دكتور تامر، هو شكله كده بيتكلم، انا بس اتاكد يا
هو
دكتور تامر.
هو شكل
ولا بيجرب؟
البرزنتيشن ده شكله معمول بالصوت، بس الصوت مش طالع لنا.
لا كده لا، كلمه. لا كلمه.
انا بكلمه.
دكتور ناصر.
ايوه يا وائل.
I will share another screen till the
لا سيبه، لا سيبه، لا ما تعملش شير، سيبه. لا ما
اوكي يا
تعملش
دكتور
شير.
ناصر. اوكي.
وتامر بيحاول يتصل بيه.
شكله سجل ف يا تامر بيكلمه.
Hello. Could you hear? Could you hear? Oh. But I.
يا وائل اعمل ميوت لكل الناس ما عدا الراجل الياباني وتامر وانا وعمر.
هو حصل
في
يا
صوت
دكتور،
ناس
هو
بتضحك.
الصوت ده يا دكتور من السبيكر الياباني يا دكتور. انا لو
معقول؟
عملت له ميوت
في ناس
دلوقتي
بتهزر،
حالا،
في ناس بتهزر مع بعض.
بص يا دكتور انا هعمل له ميوت دلوقتي هتلاقي الصوت اختفى.
طيب.
بس
يبقى من عنده فعلا، من عنده فعلا. صح.
هو غالبا عمل presentation with voice بس he didn't share the voice.
يا دكتور تامر.
هو انا بس عايز افهم انا ليه لما بعمل نفسي ان ميوت ما بيشتغلش
ايه اللي ما بيشتغلش؟
الصوت لما اجي اعمل
لا
نفسي
احنا
ان
سامعينك،
ميوت ما
احنا سامعينك
بعرفش.
اهو، احنا سامعينك اهو.
لا، ما هو دلوقتي هو سمح لي اعمل ان ميوت. هو
احنا
الراجل
سامعينك.
انا كلمته، هو هيعيد البرزنتيشن من الاول ويدخل الصوت، بس هو في مشكله عنده في الصوت.
هو
طيب
يعني
مش
عامل
مشكله.
برزنتيشن جاهزه؟
ايوه، ما هي البرزنتيشن جاهزه بالصوت، فهو هيعيد تاني. هو كان فاكر ان احنا سامعينه.
تامر هو الضيف الثاني هيجي الساعه كام؟
الساعه 2.
طب احنا هنملى الفتره دي ازاي بقى؟ هتتكلم انت؟
ممكن ادي توك انا، وفي احمد سلطان كمان عنده توك.
طيب ماشي.
Hello.
هو ما ينفعش هو يبدا يعني يتكلم برزنتيشن. لا دكتور تامر، لان واضح ان الصوت مش معمول شيء لغايه دلوقتي. يا دكتور تامر.
ايوه بيه سامعك. بتقول ايه؟
لا هو برضه لسه برضه مش الصوت بتاعه مش ظاهر. انا في رايي ان هو يتكلم عادي خالص، يتكلم از نيو برزنتيشن.
هو بيقول ان هو عنده تكنيكال بروبلم وبيصلحها.
残念。たら、あれ送ったらいいんちゃうん。あれを。あれ送るわ。そうする。ほんならもうこれ止めようか。もうこれから抜けるわ。これから抜ける。これどうしたらいいの？抜けるときは。これか。エスケープ。どうしたらいい？抜けられへん。あ、そうか。これを止めたらいいの。で、から抜けれるの。止めて、これ終わったんや、ズーム。ミーティングが。
لا ده هو طلع من الميتنج كده على فكره.
شكله هيخش تاني.
يا دكتور لو نقدر نغير السكيدول، يعني لو في مثلا برزنتيشن جاهزه
ما ينفعش ما ينفعش لا
لغايه ما يدخل.
ما فيش لا.
طيب خلاص.
تابعوا بقى، تابعوا اول ما يدخل. اعمل له ايه طبعا هو طلع غالبا هيرجع يدخل تاني.
ماشي يا دكتور مفيش مشكله.
ولو كده هيخش على طول.
ممكن الدكتور تامر تعرف منه المشكله ايه يا دكتور تامر؟
انا متابع معاه على النت.
مسجل الشريط بالصوت، هو لازم يتكلم احسن.
ما انا رايي كده، انا في رايي
يعني
كده.
هو عامل التسجيل انكلودنج الصوت بتاعه، الصوت مش طالع. لما عمل شير سكرين الصوت واطي قوي، ولازم يتكلم بنفسه.
ما انا قلت له كده برضه.
جون بينت بيذيع، بس انا قلت له يوقف لغايه لما هنبتدي من اول وجديد.
هل نخلي الدكتور تامر
يا
يقول
ريت
الطب
يا ريت
بتاعته؟
يا ريت حد تاني
ها؟
يتكلم دلوقتي.
طيب
طبعا
يا دكتور تامر،
طب دقيقة واحدة يا بيه.
انت لو الطب
لازم
بتاعتك
ينسق
جاهزه
معاه.
بس عرفه
طيب
يعني عرفه، قول له انك انت ايه هتبتدي
هبدأ
على
توك
بال ما
عبال ما
هو
هو حاضر.
ايه.
يا عمر هو يسأله مش يعرفه، يسأله.
طيب
ما ايوه،
تمام
ما انا
تمام.
بقول
ممكن
الاول
يكون هو
يا
جاهز دلوقتي، ممكن يكون هو جاهز.
دكتور ناصر كلم المدير. لا كلام لا ايه ماشي.
الو الو.
ايوه سامعينك يا دكتور ناصر،
I
سامعينك.
see. We apologize about this delay. Professor Sakai has a problem in the voice of his speech. He is trying to fix it.
This is my disclosure. At first,
I think now we
I'd like to show you
start.
the number of cases in intracranial aneurysm treatment based on annual report surgical society. Clipping surgery for ruptured aneurysm gradually decrease recent 10, 15 years. Now, about 9,400 clipping surgery in 2018, about 45% decrease against 15 years.
Dr. Sakai, we cannot hear you. The sound disappeared.
يا دكتور تامر هو واضح.
هو بيتكلم مش بيسجل.
これじゃないもんな、絶対。だって MacBook のマイクやもん。
حاجة عيب قوي صراحة، عيب قوي والله، عيب 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 قوي 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 قوي. وبعدين منين هو بريزدنت كذا؟ عمره ايه معاه بريزدنت؟ عمره بيتكلم انجليزي ولا ايه؟ ما يعرفش كده. ده اللي انا كنت ده اللي انا كنت عامل حساب. وبعدين البارتيشن بيقل. انا مش عارف والله العظيم. لو بص، العدد كام؟ نشوف العدد نزل 10، نبقى 55، كان حاجه و60 نزل 55 دلوقتي. شوف. بقول لك نزل. خد بالك بس عشان الناس ما يسمعوكش انت. ابعد عن طب. اه
So دلوقتي دكتور احمد سلطان will prepare a presentation on AVMs. He will present shortly. Could you give him the chance to share his screen?
اكتب لنا كده يا دكتور تامر على الشات عشان الناس تبقى عارفه مين اللي هيتكلم لو سمحت. هو احمد سلطان ابتدى ولا ما فيش ولا ما there is no voice؟
حد يفتح له الفويس بس يا جماعه.
دكتور مايكل. دكتور مايكل.
ايوه دكتور حاضر.
افتح للدكتور احمد سلطان.
احمد سلطان. اوكي انا كده فتحت له.
خليه يبتدي بقى يا دكتور تامر، خليه يبتدي من اول وجديد.
مفيش صوت برضو؟
حد ينبهه انه مفيش صوت من عنده.
طب ما هو جايز الصوت من المشكله دي عندنا احنا بقى. ما هو
احنا سامعين بعض كويس اهو،
هو في مشكلة في الصوت عنده يا دكتور، مش عندنا، احنا سامعين
احنا
بعض.
عاملين له ان ميوت اهو والمايك مفتوح.
هو اسمه ايه؟
احمد سلطان.
هو المايك بتاعه مفتوح بس هو مش بيتكلم.
طب كلمه يا دكتور تامر، مش هخليه يتكلم.
السلام عليكم. ايوه بيه. انا عمال اتكلم محدش سامعني، مش عارف في ايه. الو،
لا احنا كده سامعينك يا
سامعني
احمد،
كده بيه؟
احنا كده سامعينك. انت بتتكلم، انت عامل برزنتيشن عن طريق الموبايل ولا عن طريق اللابتوب؟
عن طريق اللابتوب.
طيب احنا كده سامعينك، انا سامعينك كده كويس. ابتدي
كده
بقى بقول.
كويس. طيب تمام. بسم الله الرحمن
ممتاز
الرحيم.
ممتاز.
My talk on the cure of cerebral EVMs after partial embolization. Is it a chance or a hemodynamic process? The EVMs are complex vascular lesions without standard treatment, and the treatment is always individualized according to the institutional and personal experience. The main aim of EVM treatment is to prevent further hemorrhage or to treat the associated symptoms like headache, seizures, and to treat mass effect in huge and large EVMs, and to treat the stale phenomena that can lead to ischemic changes in the surrounding brain. We have 4 lines of treatment for EVMs: microsurgery, stereotactic radiosurgery, embolization, and observation. Today, we have a tremendous progress in the last 15 years in EVM treatment, especially with endovascular embolization. After the introduction of endovascular embolization, the rate of cure is increasing nowadays by use of liquid embolic agents, and also by the advancement in microsurgery and stereotactic surgery and the combined line of treatment. If endovascular embolization can be used for a cure of small-sized OVM, grade 1 or grade 2, according to Spitzel and Martin classification. And also, embolization can be used partially in the multi-session treatment of large OVMs before microsurgery. It gives a good chance for the surgeon to decrease bleeding, especially with deep feeders. Also, before a stereotactic radiosurgery, it allows volume reduction of the AVM. Target embolization in cases of medically intractable seizures, progressive deficit secondary to arterial stale or mass effect, to occlude an associated aneurysm, and to occlude high flow fistula. And we know that high flow fistula leads to bleeding. And also, it does not respond to stereotactic radiosurgery. Partial embolization sometimes may be dangerous. Some cases that have partial embolization bleeded after the partial embolization because of the hemodynamic disturbance that occurred inside the AVM. As we said before, microsurgery, it allows the occlusion of deep feeder, it allows volume reduction, so it can decrease the bleeding in the surgery of EVM. Before radiosurgery, it allows volume reduction. In our series, in about 200 patients embolized in the last years in our Alexandria University, we have 18 patients with symptomatic EVM that were partially embolized, and we found on the follow-up angiogram that the EVM disappeared. The 18 patients ranged from 7 years up to 42 years. And most of the cases with young patients, most of the cases with female gender, and most of them presented with intracerebral hemorrhage. 83% presented with intracerebral hemorrhage. Three cases presented with FETs. Most of the cases have one vein draining, and 5 cases has 2 vein draining. Only 3 cases has 3 vein drainage. Most of the cases had superficial venous drainage in 12 cases. We have cases with that have 7 associated aneurysms. The AVM size was mostly less than 3 centimeters. And the Spitzel-Martin grading was 2 in 11 patients. Most of the patients were embolized in one session, and there is no permanent neurological deficit in the cases or mortality. This is the first case. This is a female patient, 19 years old, presented with intraventricular hemorrhage, and the angiogram show a thalamic EVM supplied by the right posterior cerebral artery and drained inside and drained to the straight sinus and deep venous system, to the vein of Galen and deep venous system. This is the intraventricular hemorrhage, and this is the signal voids in MRI. This is the angiogram. This is the angiogram again. This is the AVM supplied by the right posterior cerebral artery and drained by the deep venous system. After partial embolization, we choose the 3 feeders and we infused the histoacryl inside the AVM, and then we stopped for a next session. And this is the angiogram after partial embolization. We can observe that the venous drainage is delayed after occluding the 3 feeders. The angio again, we can find that this is the nidus and this is the venous drainage is delayed after partial embolization. And during the preparation for a second session, the AVM completely disappeared. After 6 months follow-up, this is the angiogram. There is no residual nidus. And this is the video showing no nidus and no venous drainage we can observe in the angiogram. And after 1 year, we did an MRI showing recovery of the, after recovery of the patient, we can observe the follow-up MRI showing the CT, we have the shunt, and this is in the CT, we can observe the histoacryl cast, and this is the MRI showing complete disappearance of the AVM nidus after partial embolization. Another case, a 41-year-old male patient presented with acute attack of intraventricular hemorrhage due to a left frontal and intraventricular EVM. This is a CT scan showing an intraventricular hemorrhage, and we can observe the serpiginous blood vessels near the ventricle. And this is the DSA showing the EVM. This is the nidus. This is the anterior cerebral supplying the AVM, and this is a deep venous drainage to the vein of Galen, internal cerebral vein of Galen, and straight sinus. This is a grade 4 AVM, and we did multiple sessions, 3 sessions of embolization using histoacryl. We can observe that this is a cast of the histoacryl, and this is the residual nidus. After the last session, we have a small nidus, and the vein is still apparent here. And after, this is the angiogram showing the residual nidus after 3 sessions of embolization. We can observe that the venous drainage is delayed to the late arterial phase in the EB and lateral angiogram. This is the nidus, and this is the venous drainage of the AVM. And this is the follow-up angiogram showing complete disappearance of the nidus. This is the right internal carotid, and the previously seen nidus disappeared completely, and the draining vein is not found now. And this is, excuse me, this is the angiogram after complete disappearance of the nidus. This is the right internal carotid, EB and lateral view, and left internal carotid, EB and lateral view without any residual nidus. case 3, a 27 years old female male patient presented with fits due to left frontal EVM Spitzler-Martin grade 2. This is the MRI showing the signal voids. This is the CT scan showing some calcification in the left frontal lobe and edema. And this is the angiogram showing the EVM nidus supplied by the anterior cerebral artery mainly. And we have superficial venous drainage. This is the first session of embolization with onyx. This is the residual nidus. This is the residual nidus we can observe. This is the video. We have a small residual nidus. This is the nidus. And the venous drainage is delayed to the late arterial phase. This patient lost follow-up for 1 year, and this is the plain X-ray showing the onyx cast. After 4 months, we did another angiogram showing still a small residual nidus. This is the residual nidus. Again, the same onyx cast. After 1 year, we prepared the patient for another session of embolization. Complete disappearance of the AVM nidus after 1 year. This is the right internal carotid artery angiogram. There is no residual nidus. Complete disappearance of the AVM and the draining vein. This is the follow-up after 1 year. Complete disappearance of the AVM nidus. My conclusion, partial embolization can be curable in some cases of EVMs. The main issue is to find that the venous drainage is delayed to the late arterial phase, and most of the cases have superficial venous drainage, and most of the cases with less than 3 centimeters in size, and the AVM show delayed the AVM drainage, the venous drainage is delayed to the late arterial phase or in the venous phase. What is the benefit of partial embolization in such cases? It helped us to decrease the number of navigations, the number of catheters, and the number of embolic agents. Sometimes if you give a large amount of embolic agent inside the AVM, it leads to hemorrhage. This is reported in the literature. And also it decreases the cost of treating our poor patients. Thank you.
Thank you, Dr. Ahmed. Is there any, we will open the panel for discussion until you are ready with the next presentation. If anyone has a question, please start to write your questions on the group chat. Okay, until the, I have a question. Do you have a plan to increase those patients in the future, so you can have some kind of statistics regarding the number of feeders and the number of drainers and which patients will and how the percentage of embolic material? What is any useful application of this study in your future embolization of AVMs?
We already doing statistics for those patients, and the percentage of those patients among the whole number of cases in Alexandria, and to how can we choose patients in the future, and for partial embolization to decrease the cost we have superficial venous drainage for most of the cases, and the AVM size less than 3 centimeters, and from 1 to 3 feeders only.
Okay. We have another session now about difficult case discussion. We will prepare until the second speaker joins.
There is some questions from on the chat. The first question, what about your experience with venous approach for treatment of VM? I am still not doing the venous approach. We will try in the future. I think venous approach is now established itself for the cure of AVM treatment. We have a problem with the materials and the balloon needed to occlude the vein during embolization. The second question, these are arterial type of ligation embolization, what cause increased risk of hemorrhage if not dealt with surgery? Do you still advocate such approach? Yeah, I cannot understand the question exactly, but we are talking the results of this study was found what was intended from the start. Our aim is to occlude the AVM totally by embolization, but we did this on multiple sessions, and those patients give us this point of view during embolization. We started with one session, and during the follow-up, we found that the AVM disappeared. We tried to explain this by the hemodynamic process that occurred, and we found that on all cases, the vein drainage is delayed. So this approach may be good if the venous drainage is delayed at the end of embolization. Another question from Dr. Muhammad Farouk. Excuse me, you mentioned that you perform embolization before stereotactic radiosurgery. However, literature states that embolization actually decreases success of radiosurgery. What do you think? We know that the radiosurgery needs a volume of less than 3 centimeters. And the aim of embolization here is to do volume reduction. If we have a grade 3 EVM with a large size named 5 centimeters or 4 centimeters, radiosurgery will not be effective to such large size. So our aim is to do volume reduction. In some studies, the embolic material may decrease the efficiency of radiosurgery, but we have no choice or in such large sized EVMs. My voice is heard?
Yes, yes.
What about using embolization after radiosurgery to facilitate the effect of stereotactic radiosurgery? We have some cases that we embolized after radiosurgery. Some patients were sent to radiosurgery, but they recurred with bleeding during the latent period. We know that the stereotactic radiosurgery need 2 years to show occlusion of the AVM. Some cases recurred with bleeding after stereotactic radiosurgery, and we embolized them after stereotactic radiosurgery. Some cases were embolized partially, and some were embolized totally, and we have good effect and good recovery of those patients. Venous drainage is delayed when the embolization is performed. There must be some other factor as well, not only delayed venous phase. This is another question. Yes, this the AVM. I think it is the cure of AVM after partial embolization is a multifactorial. And it is depends on the hemodynamic changes that occur inside the nidus after partial embolization. Also, I think that the embolic material may have an inflammatory effect that help to increase the possibility of cure of the AVM. Another question, what is the earliest time to do diagnostic angio after acute spontaneous ICH? This is another question. If you face a patient with intracranial hemorrhage, a young patient with suspected an AVM, you should do a DSA as early as possible, because you don't know what is the source of bleeding. The source of bleeding may be an aneurysm, and it may bleed again. So we advise everyone to do an early DSA, and if there is no high risk of, if there is no a large aneurysm or an aneurysm that can bleed again, you can do another DSA after disappearance of the hemorrhage. So early and late DSA is advised in those cases with spontaneous ICH. Any other question?
Okay, I think now we have time for some company information about the drug, and then we will start difficult case discussion until Professor Tanikawa join us. He will join us at 1:30. So if the company has a short talk, please start.
Okay, many thanks, Dr. Tamer. Many thanks to Professor Dr. Nasser El-Ghandour. I am Dr. Wael Mus'ad from EVA Pharmaceutical Company. It is an Egyptian international company. We are talking today about one of the neuropathic painkiller, one of the most potent and effective FDA approved once daily neuropathic painkiller is Sympatix. Sympatix, it is a duloxetine. It has 3 concentrations, 20, 30, and 60 milligram concentrations. First of all, Sympatix acts as a painkiller, neuropathic painkiller in different indications like diabetic peripheral neuropathic pain, chronic low back pain, fibromyalgia, and also osteoarthritis pain. The Sympatix is a member of SNRI, serotonin norepinephrine reuptake inhibitors. It blocks the reuptake of the neurotransmitters, which is the serotonin and the norepinephrine, by the presynaptic nerve, and thus increase the level of these 2 neurotransmitters in the nervous system. Sympatex has several recommendations and the first guideline in several guidelines as a first line of treatment in neuropathic pain through international and regional guidelines like International Association for the Study of Pain, European Federation of Neurological Societies, French Pain Society, and also Danish Pain Society. So Sympatex is considered as a first line treatment in several neuropathic pain. Sympatex also has an FD approval in chronic low back pain like sciatica, spinal stenosis, herniated disc, and also ankylosing spondylitis. I will share with you some studies concerning with the neuropathic pain and the treatment of Sympatex in chronic low back pain. This study is a 12-week study, 12-week trial, randomized parallel placebo-controlled double-blind study. The duloxetine-treated patient or patient who are treated with Sympatex showed a significant greater pain reduction on the pain scale as early as 1 week from starting the treatment with Sympatex. Also, there is another study which is dealing with Sympatex in chronic low back pain. It was a 41-week uncontrolled dose blinded study. The result of the study shows that along the 41-week and also extend to 54 weeks treatment with Sympatex encourage the Sympatex encourage in controlling the chronic low back pain for extended period of time. And through this long period of treatment, it is well correlated. No new safety concern were noted in the extension phase. Sympatex dose for Sympatex is 30 milligram once daily, which result in a better compliance to the patient. For more severe cases, those can be initiated as 30 milligram for 1 week and then increased to 60 milligram once daily. No relation with food. It can be taken with or without food. Finally, Sympatex has 3 concentrations, 20 milligram, 30 milligram, and 60 milligram. It has an FD approval in several pain conditions like diabetic peripheral neuropathy, neuropathic pain, fibromyalgia, chronic low back pain, and osteoarthritis pain. It has a dual mode of action. It acts on both as a neuropathic painkiller and also mood stabilizer, and thus improving the patient quality of life. Patient compliance, it has a better patient compliance through the single daily dose, excellent durability, low incidence of side effects, which subsides quickly after use through 2 or 3 or maximum 4 days post-treatment. Also, Sympatex has several evidence-based medicine, have several evidence about and the guidelines about that the efficacy of the Sympatex and as it is a first-line treatment for neuropathic pain. Finally, thank you. It is our proud as Eva Pharma company to thank Dr. Nasser El-Ghandour, the president of ESNS, and to thank the speakers and the moderator for let us sharing our products in this international webinar. Thank you. Dr. Tamer?
Yes, thank you very much.
Thank you, Dr. Tamer.
Thank you very much.
Hello.
So we will have a case discussion session until 1:30. The Professor Tanikawa will join us. May I have, can I share my screen? Is it, can you see my screen?
Yes, we are watching your screen now, Dr. Ahmed. No, please reshare your screen again, Dr. Ahmed.
Can you see it now? Is it clear? Can you see my screen?
Yes, yes, doctor.
Okay. So this is a 26 years old male patient presented to us with a typical gelastic seizures. The patient, whenever you tell him anything, he has a gelastic seizures. He started to laugh. Very common symptoms that happens with hypothalamic hamartoma. He has a lower nerve palsy. He has 2 attacks of ICA syndromes 2 years ago and several years ago. And he is hypertensive patient, not known to be a familial hypertension. He's 26 years old only. This is the CT we did for him. This is the angiogram. You can see this is the residual lumen of basilar thrombosed, large thrombosed aneurysm, and this is the CTA in several cuts. So, what is the? Do you have any plan of treatment? Could you suppose any plan of treatment? What should we do? Should we treat conservatively with medical treatment? So if anyone has suggestions, please start to write. Okay, so what we did for him is we did a balloon occlusion test, and in this balloon occlusion test, we occluded both vertebral arteries. We did left vertebral artery occlusion, and then we did the right vertebral artery occlusion, and we found this left PCOM constructing the upper basilar territory. A balloon occlusion test is done under local anesthesia. Patient didn't complain of any neurological deficit during this test. And what we did after this is a whole basilar trunk occlusion. We filled all the basilar artery with coils and put a large coil mass, about maybe 16 coils or something, and we occluded the basilar artery completely. This is the final angiogram after complete basilar artery occlusion. You can see reconstruction of the upper basilar territory from the PCOM. 3 months later, we did an angio, and we found the PCOM has started to be bigger in size. So this is the first case. If you have any comment on it or discussion, we can start to discuss. I don't know. فادي بيسأل على البيكوم سيركيوليشن، عن احنا لقينا ليفت بيكوم بس. فليفت بيكوم ده كان كفايه انه ريكونستراكت الابر بازلر تريتوري. Why not to use a flow diverter? It's a good question. So actually the يعني الثرومبس already filling the aneurysm all around. where you are putting the flow diverter inside the thrombus. And you cannot guarantee which direction. In some patients I saw in the literature, the flow diverters going inside the thrombus itself. And the mass effect, I don't know if it's going to resolve after flow diversion or not. النقطة الثانية landing point، انت ما عندكش نقطة landing ولا عندك نقطة تبدأ فيها healthy، يعني هو كل ال circumference of the basilar artery is pathological. That's why we decided to occlude the basilar artery, and the patient did very well for several years. I have been following him now for more than 10 years. Any other questions? اوكي this is كويس دكتور عمر معانا في الحاله دي برضه لنا رايه فيها. دي 35 سنه. الصوت واضح؟
Yes, clear.
اوكي دي عندها 35 سنه، كان عندها history of cancer breast several years ago. Severe dorsal pain, not responsive to medical treatment. We did this MRI T1 and we found this lesion in T1 image, and you can see destruction of the vertebral body in the CT, and this is the bone scan, single metastasis. So what is the surgical approach? Posterior fixation, costotransversectomy, thoracotomy or posterior fixation. كل دي options احنا كان ممكن نعملها. بس هي الفكره العيانه دي عندها لما عملنا spinal angio we found the Adam-Kivics artery coming at the same level of the destructed vertebral body. So if we approach the patient from lateral we could occlude the radiculomedullary artery. وده خلى الديسيجن بتاعنا this changes our decision rather than to do a thoracotomy to go posterior by posterior approach. So we went by posterior approach and we removed the pedicle and we put a bone cement and fixed only one level, and the patient did very well. فهو
you mean you did this angio as a routine or only in particular in this case only?
We did this angio as a part of a trial to see if this lesion is vascular and we need to embolize before surgery or not. So when we did the angio, we found the artery of Adam-Kivics coming at the same level, and it's only a single artery. That's why we did the.
This means do you recommend for any dorsal surgery? It's better to do angiography to know the level.
Yes.
You a good benefit from this angio. It means it should be as an or opinion.
بالظبط كده يعني that's what we recommend to check the radiculomedullary artery before doing the procedure. And sometimes there are 3 radiculomedullary arteries, sometimes there are a single one called Adam-Kivics, and if you injure it, the patient may go after with a neurological deficit. Okay, so I have Are you still seeing my screen or it stopped?
No.
Okay, Professor Tanikawa already joined.
Very nice.
Please unmute Professor Tanikawa.
Please let the Dr. Nasser to welcome him, please. Dr. Nasser.
Yes, please. And unmute him, please. Unmute him.
Hello. Dr. Nasser. دكتور ناصر.
Hello.
Okay, hello, Dr. Tanikawa. Tanikawa Sensei, how are you?
Thank you very much. I am sorry for my.
Otskara-sama deshita. Had a long day. I heard you did in this morning a case patient with carotid endarterectomy.
Yes.
Okay, that's
Exactly.
perfect.
Yeah.
Okay, that's perfect. So we are welcoming you. As we know, Professor Tanikawa is a very well-known international neurovascular surgeon. He is a super bypass expert, and we are glad to be here. He's a director of neurosurgery department in the Sapporo. So we are welcoming him now to have this lecture with us, and organized by the educational web seminar of the Egyptian Neurosurgical Society. Please start.
First of all, please, before starting the presentation, let me welcome Professor Tanikawa for joining our webinar. We are happy that you are accepted our invitation. Thank you very much. My name is Nasser El-Ghandour, President of the Egyptian Society of Neurological Surgeons. Thank you.
Thank you very much. Thank you, professors. I'm very honored to be invited to such a wonderful online web conference. And as well, it is my pleasure to share my experiences in the 30 years. Today, I'd like to talk about the transcription approach and principles of microanastomosis. I always think that what is the accuracy of the neurosurgery? It is a confirmation of the anatomy in every step. We should, please, could you hear me?
Yes, we can hear you very well.
Okay. Can I continue?
Yes, for the moderator of the company, please unmute everyone. Please unmute everyone. So please continue.
Okay. The accuracy of neurosurgery depends on the confirmation of the anatomy in every step. We should confirm the anatomy in every step. And to see the object in the operative field, this is very important. Everybody understands it, but to see the object, the operative field must be clean, must be bloodless. This is quite important. It is easy to say, but it is difficult to achieve this situation. And to get a bloodless operative field, you guys, everybody knows hemostasis is most important. As well, to see the object properly, the appropriate approach is necessary. I'll show you the actual example of the hemostasis until opening the dura. This is the left side front temporal craniotomy. After elevating skin flap, the temporal muscle is elevated posteriorly from the temporal line, and the heart-shaped front temporal craniotomy is performed like this, and the remaining sphenoid ridge is taken out, and the orbital skeletonization is performed to get the widest operative field in a skull base. This is a complete hemostasis before opening dura. Basically, in my institute, I force young guys to get a complete hemostasis before opening dura like this. This is a principle in craniotomy. And another principle is dimension, basic dimension of the microanastomosis. When we perform the end-to-side anastomosis, like STA, MCA bypass, I always perform the fish mouth trimming at the end of the donut with a 60-degree oblique cut like this, and the same length of here, same length cutting up from the 60-degree oblique cut, same length cutting up. Then we can make the fish mouth trimming. In this dimension, if the shrunk diameter of the donor, it was defined as large D, this can be calculated pi times diameter of the donor divided by 2. So this length should be 2 times of the shrunk diameter divided by √3. So totally, the total length of the fish mouth trimming, the stitching length should be 4 times of D divided by √3. This means that approximately 2.3 times of shrunk diameter of donor vessel. This is a basic dimension when we perform the fish mouth trimming. And as well as fish mouth trimming, the everting technique, the eversion of both vessel wall, donor wall, and the recipient wall must be attached face to face. Then, with this situation, it's easy to penetrate the whole vessel, 2 vessels. This is a principle to perform the exact microanastomosis. If the donor vessel wall or recipient vessel wall was this has this wall thickness, the stitching bite should be twice of wall thickness, and the interval of each stitch should be 4 times of wall thickness. This is a so-called square stitch. With square stitch, we can get no leakage in between the intervals after opening the parent arteries. This is the illustration of the side-to-side anastomosis, which was drawn by Professor Kamiyama, who is my mentor. He's working with me now in my hospital. Anyway, when we perform the side-to-side anastomosis like this, the arteriotomy should be performed symmetrically like this, C-shaped symmetric arteriotomy in both sides, and the bottom side suture should be running, and the superior part of suture should be interrupted. It's a stitching way of the side-to-side anastomosis. But some of you has already realized that in side-to-side anastomosis, bottom side wall is not everting, it is inverting, because the bottom side vessel wall, both wall is attaching at adventitia to adventitia. So, and here, the cutting edge of the arteriotomy is exposing into a vascular lumen. Even after stitching with running suture, the collagen fiber in the cutting edge of the vessel wall is exposed into the lumen. This may cause acute thrombosis after the opening the temporal occlusion of apparent arteries. So, to avoid acute occlusion in side-to-side anastomosis, we should make the orifice bigger as much as possible. To do this, basically, I recommend you to make the arteriotomy length 3 times longer than the diameter of the parent artery. So this length should be 3 times of the diameter. This is a principle to avoid acute thrombosis in side-to-side anastomosis, because this is a side-to-side anastomosis. For example, it is useful to revascularize distal ACA, anterior cerebral artery territory, or both either pica, posterior inferior cerebral artery territory by revascularization. This is very good anastomosis, but if you fail the anastomosis, if you have an acute thrombosis here, you may lose both vascular territory. You may have the very big infarction in both cerebral hemisphere or cerebral hemisphere. So this is a very useful anastomosis, but we have to be careful. I'll show you representative cases of a transribbon approach. This is an unruptured posterior projecting PCOM aneurysm, not so big. The CT angio shows posterior projecting unruptured PCOM aneurysm. This is the right side approach after front temporal craniotomy with a complete hemostasis of epidural space and with no red cell with the highest magnification of the microscope. We can separate Sylvian fissure without sacrificing any vessels, any veins. Now you can see the aneurysm is attaching to a temporal uncus, and the retracted temporal uncus, it makes the operative field easier to confirm the arachnoid trabecula between distal internal carotid artery and the temporal uncus, like this. And after placing the brain spatula at the temporal uncus, between the temporal uncus and the aneurysm, you can see the oculomotor nerve surrounded by arachnoid trabecula can be exposed between temporal uncus and internal carotid here. This is aneurysm and a PCOM. Very proximal important perforator from the PCOM could be confirmed with the highest magnification like this here. And I am putting the neck clipping completely and preserve all the PCOM and all the perforator of anterocranial perforating arteries. Another case, a 57-year-old man, ruptured basilar top aneurysm, relatively wide-based 57-year-old man. He's a physics teacher in high school. Asymptomatic basilar top aneurysm, but a larger one. This is the right side approach. The video is not a high definition. This was a standard definition video. This is operation in 2007, 13 years ago. Anyway, the distal transribbon approach, I usually begin the arachnoid cutting at 5 centimeter, 50 millimeter distal from the temporal tip. Then, at first, you should go into the intra-cistern like this, and inside the arachnoid trabecula with highest magnification to make the space to put the brain spatula on the temporal lobe like this. After opening the intra-cistern, exposing M3 segment partially, and this is a branch of anterotemporal artery coming up to a distal temporal lobe. Here, arachnoid trabecula between the temporal artery and the frontal lobe can be seen, and looping a small vein from a frontal to a temporal lobe can be seen. The arachnoid, tiny arachnoid trabecula between the small vein and the temporal lobe can be seen. So if you can see even such a tiny structure, it is easy to cut with the highest magnification of microscope. Current microscope usually the more than 20 times of magnification, so it's good enough to confirm the microstructure like arachnoid trabecula, small veins in a Sylvian fissure or interhemisphere fissure. Anyway, you can see with the highest magnification and the appropriate training to suppress the physiological tremor of your hand, then we can incise only arachnoid trabecula and separate frontal and temporal lobe, atraumatic separation. Even such a small veins can be dissected, can be saved, prepared. And here is anterior tentorial edge connecting to an anterocranial apex. And MCA bifurcation was confirmed. Then now I am approaching to a proximal M1, a so-called Sylvian varicula. And this is a tiny arachnoid trabecula between the frontal and temporal lobe, which is covering a carotid system. Now, panoramically, you can see the distal internal carotid artery and M1 horizontal segment. Even such a tiny arachnoid trabeculus between the M1 and the frontal lobe and the lenticular striate artery, all the anatomy can be confirmed. And in this situation, now the oculomotor nerve is pulled posteriorly by the arachnoid trabecula because the temporal unx is a bit retracted by a brain spatula. So the arachnoid trabecula between the oculomotor nerve and the temporal unx must be cut. Then oculomotor tension is released. Now the oculomotor and the P2 segment, P2A, and anterior choroidal artery can be seen, which is anchored by arachnoid trabecula. By opening the Lilliquist membrane medial to oculomotor nerve, you can find the basilar trunk and the distal basilar artery, which have the atherosclerotic plaque just proximal to P1, PCA. The very small occluded PCOM could be insides, and I am confirming the contralateral P1 origin and the contralateral posterior term perforating, contralateral oculomotor nerve. And now I am coming to ipsilateral side, ipsilateral P1. I am confirming the origin of a contralateral oculomotor nerve. You can see it. I have already put the temporal clip on the basilar trunk, just proximal to SCA. Now, in this situation, I have confirmed no perforator is attaching on the behind aneurysm, and both perforators, posterior term perforating arteries, is completely separated from both the aneurysm neck. Then you can put the neck clipping. This clip is 762 large slide curved clip. And the small remained part is clipped with the, this is a 694 mini clip, Yashaji mini clip. Now, CT angio immediately after surgery shows a complete obliteration of the aneurysm and perfect patency of the PCA. Next case is a low position basal top aneurysm. You can see the neck of aneurysm is a very low position, lower than the postecrinal process. Now, I am trying to preserve all the veins, superficial cerebellum vein, which is connecting to a sphenoparietal sinus, and another tributary is connecting to a basal vein of Rosenthal. In this situation, it was impossible to preserve the veins in only subdural approach. So I switched to epidural space in order to mobilize the veins posteriorly with dura. Now, the dura peripheral is elevated from supraorbital fissure, and partially I open the oculomotor foramen like this. And I have already confirmed the third nerve, fourth nerve by elevating dura propria from cavernous lateral wall. This is a Lidicus membrane lateral to oculomotor. And here, that is a postecrinal process because in this case, the proximal basal trunk is hidden by postecrinal process because of a low position. Now, in this case, after exposing a postecrinal process by opening the dura, I am drilling with the ultrasound bone curate. And now you can see we could secure the proximal basal and confirm all the perforator, especially behind the aneurysm, of course, bilateral postterm perforating arteries. Most important perforator behind the aneurysm could be confirmed. And nothing happened in this patient as well. This is the actual example of a trans-ribbon approach and modified extended approach, so-called anterior temporal approach to distal basal aneurysm. I'll show you another example of the kissing aneurysm using a retrograde suction decompression technique through the suprathyroid artery. Now, this is not a kissing. This is a relatively large aneurysm. Patient come with a visual disturbance. This is a case I operated in Russia last year in St. Petersburg. Now, I am cannulating into a suprathyroid artery to perform the retrograde suction decompression through the suprathyroid artery. This is a left side M3 segment on the temporal lobe. I am performing the STA MCA bypass as an assistant bypass to secure the blood flow, even something happened during neck ripping something. But this is the STMC bypass, and I am confirming the patency, and it was good. And this is the aneurysm. I am putting a temporal grip proximal to PCOM, distal to the aneurysm, and in the neck, I put the temporal grip on the ECA and the Brudoc on the common carotid. Then through the suprathyroid, the assistant can suck the blood to decompress the aneurysm. Now, I can confirm the aneurysm is compressing the optic nerve. And in this case, the aneurysm was originated from the epidural space, and the distal dural ring is expanded by the aneurysm. I am incising the distal dural ring. Here is the part of optic sheath. Optic sheath is opened as well. And aneurysm neck is exposed completely at the distal and the proximal. with a retrograde suction decompression, the aneurysm is completely soft and slack, and it's easy to put the clips like this. Now, you can remove the temporary clip and the brood of at common carotid, then you can deflow the internal carotid. At this moment, the aneurysm gradually expanded. I have a doubt, still aneurysm is alive. So I inside the aneurysm and confirm the breathing. So you can see the slight breathing is coming out. So I am confirming where the patent point of the aneurysm. So the medial part of the aneurysm was has a very thin wall. So I put the penetrated clip to occlude the medial part of the aneurysm. And I put several additional clips. And I got a complete obliteration of aneurysm. And nothing happened in this case. This is an actual example of a retrograde suction decompression for large internal carotid. This is an example of the kissing aneurysm, left side. Anterochoroidal aneurysm and the PCOM aneurysm is kissing each other like this. At this moment, it is very difficult to detach the both aneurysms safely. So I open the neck, left side, and cannulate into a suprathyroid, put a temporary clip distal to the aneurysm, and I am exposing a PCOM. And put a PCOM and common carotid occlusion, ECA occlusion, and with the retrograde suction decompression through the suprathyroid, you can separate the aneurysm safely. And this is the anterochoroidal artery. Parent artery is attaching to the distal aneurysm. I am preserving anterochoroidal artery and put the complete neck clipping on the choroidal aneurysm. Here is the dissection of the PCOM aneurysm from oculomotor nerve. You can see the anteterm perforating, which was arising very proximal of the PCOM, could be detached from the medial neck of aneurysm. Then you can put the clip completely with preserving the older perforator of a PCOM. Next case, 66-year-old female as well. This patient has a kissing aneurysm like this. At this moment, I am advising you should perform the retrograde suction decompression by opening the neck. But my young colleague refused to do that. And he tried to put the tentative clip with a temporal occlusion of suprachiasmatic carotid. But at this moment, neck laceration happened. So I immediately strapped in and confirmed the laceration. Here you can see that is the penetration of the neck. This is a reason why the kissing aneurysm of PCOM and the choroidal artery kissing aneurysm is difficult. Without the sufficient decompression, it's impossible to separate the kissing part. This is the biggest reason why I recommend the retrograde suction decompression technique through the suprathyroid artery. Now, I repair the injured point with a tensile suture with the direct stitching, and the remaining anterochoroidal artery aneurysm could be clipped. ICG shows the occlusion of PCOM. What happened? I reopened under the temporary trapping. I irrigate inside of aneurysm and inside of PCOM, and I am confirming whether breathing come or not. Breathing come, so this means that at least PCOM origin and aneurysm is still patent. So I can decrypt the neck of the PCOM aneurysm and confirm the Doppler sound, and the ICG shows a good patency of PCOM. So I could confirm the PCOM recovery and the corridor artery is patent. I close the head, and immediately CT angio shows the occlusion of PCOM. Diffusion image of MRI shows a small high signal of a temporal lobe. So immediately I return to operative room. Now, the PCOM still occluded, so I decided to perform the STA PCOM bypass to save the PCA territory because this patient PCOM was a fetal type, no P1. So I put the STA PCOM bypass, and I could limit the infarction of the temporal lobe. You can see MRI shows a good patency of STA PCA bypass, and kissing aneurysm at the PCOM and the corridor artery was completely neck clipping. Anyway, we have published the retrograde suction decompression technique for clip occlusion of aneurysm. This is published on World Neurosurgery in 2016. You can find it. Next, I'll show you an anterotemporal approach. This is a unruptured basilar SCA aneurysm, the relatively high neck position. In this case, because of a high position of aneurysm, I did zygomatic arch removal, and complete dural hemostasis, and distal transradian anterotemporal approach. Now, the retrocaudal space is exposed, and the temporal uncus is retracted posteriorly, and the corridor artery and the PCOM is detached from the temporal uncus, and this is a conformation of a basilar trunk. I put the temporal clip on basilar trunk. This is a contralateral PCA. Now, the aneurysm was attaching on the origin of a oculomotor nerve, and here is the proximal of a ipsilateral P1, and a very small perforator arising from the behind the aneurysm. So, to save the such an important perforator like this, with the highest magnification after neck clipping, I am confirming the old anatomy, whether old anatomy is preserved or not. And MRI scan shows nothing. The CT angio shows a complete obliteration. This is an illustration before and after surgery by my young colleague. Next, I'll show you an 84-year-old female, ruptured large basilar top aneurysm, 84. At first, patient was comatose, so we did conservative treatment with blood pressure control. But with conservative treatment, patient recovered, patient consciousness recovered. So we had a discussion with the patient family, and strongly they wished the complete surgery. So I decided to perform the epidural front temporal approach to expose the aneurysm, epidural anterotemporal approach, and here the retroparietal space above the PCOM. The PCOM was tiny in this case, and the basilar trunk could be secured in retroparietal space, and the contralateral PCA is temporarily clipped. And this is the ipsilateral PCA, P2 to A and ipsilateral SCA. You can see here, this is the ipsilateral neck. Ipsilateral posterior perforating artery is attaching on the neck. And I am confirming the important perforator arising basilar bifurcation behind the aneurysm. All the important perforator is detached from the aneurysm. This is a contralateral origin of oculomotor nerve in interpedunculair system. With a complete confirmation of all the important perforators, contralateral, behind the aneurysm and ipsilateral, now I am putting the tentative neck clipping, preserving the all the perforator. I'm confirming the tip of the clip, and in ipsilateral side, you can see the several perforators still put anchored by arachnoid trabecula. So I am incising the arachnoid trabecula, then release it. At this moment, I could cut the tiny PCOM at the PCOM P2 junction and put the additional clip on the aneurysm. And this is the adhesion of aneurysm to the third ventricle floor between, in between the mammillary body. I have a still doubt of the arrival of the aneurysm, so I am confirming whether it is dead or not. Now, this is the rupture point of aneurysm, no bleeding comes, so I could confirm aneurysm is completely dead. Now, you can remove the temporal clip on the basal trunk, and the ICG shows complete obliteration of aneurysm, all the sparing of the important perforators behind the aneurysm, bilateral posterior perforating. And this is the final view after closing dura, and the CT angel shows a complete obliteration of the aneurysm, no remnant, and patient recovered well, fortunately. This is an example. I'll show you a STMC bypass for complex aneurysm. This is a 45-year-old female. Right side M1 fusiform, tortuous fusiform aneurysm. This is not a circular. This is a fusiform M1 aneurysm. She is an actual doctor of gynecology. So in this case, aneurysm neck clipping is impossible. It is necessary to revascularize the MC territory at least to trap the aneurysm. But the problem is where the lenticular artery is arising. If lenticular artery is included in the aneurysm, it is impossible to trap. In such case, we have to do a proximal occlusion with a distal STMC bypass. So anyway, at first, our plan is a double barrel STMC bypass on the M2 segment, both M2 segments, before attacking aneurysm. Here, this is an inferior part of inferior trunk of M2 and the STMC bypass. This is the finishing first anastomosis, and this is a second bypass. to a super trunk of M2. Another ST branch, the frontal branch and the parietal, both branches are harvested to do a double barrel bypass. This is a super trunk of M2 as well, and two-side anastomosis. This is a heel side state suture and a toe side state suture. I usually use a 10-0 for STMC bypass. And this is an intermediate state suture. And you can see if the everting situation, the everting makes easier to penetrate the whole vessel wall. Now, both bypasses opened. The ICG shows a good filling of both M2 trunks. Now, aneurysm is exposed, very tortuous. This is the proximal M1, and this is the distal M1. The aneurysm tentatively trapped, and the ICG shows a good filling of the lenticular arteries, distal lenticular, lateral lenticular, and medial lenticular. After opening the aneurysm, I decompressed, and no lenticular arteries are arising from the aneurysm. I could confirm it. Now, in this situation, it looks possible to perform the end-to-end anastomosis of M1 like this. Because of the very thick wall of both ends of M1, it was relatively difficult, but not impossible to stitch. I am using the running suture with this is a 820 Pronova. With the running manner. And this is a final stitch. And tie the anastomosis. Now we can open the anastomosis. In this situation, the double barrel bypass secures the blood flow to a distal MCA, so you can spend the time to complete the end-to-end anastomosis of M1 like this. The ICG shows a good fitting, lateral lenticular straight as well, well filled, and all the perforator is saved, and the CT angel shows a good fitting of the double barrel bypass and anterograde flow of M1 segment at end-to-end anastomosis. Patient had no neurological deficit, discharged well. Next case, I'll show you a high flow bypass. A 49-year-old man, suboptimal hemorrhage, blood blister aneurysm. At first, I did the STMC bypass to perform the MC pressure monitoring, and I made a high flow bypass using radial artery between M2 and ECA. Here is the rupture point. I am confirming the rupture point. Now, the rupture point has injured, so I put the temporary occlusion on the cervical internal cartilage and put the temporary clip to trap the rupture point. Then I open the radial artery graft under the MC pressure monitoring through a STMC bypass. Now I am putting a clip to save the to preserve the anterior corridor artery and the PCOM. Anterograde flow can be finished into a PCOM, and the retrograde flow through the high flow bypass can come into anterior corridor artery. I put a clip obliquely to save the PCOM and anterior corridor artery. And this is a CT angio immediately after surgery. And fortunately, patient recovered well. No neurological deaths. I skip this. Next, I'll show you troubleshooting. This is a 77-year-old female giant supracranial carotid aneurysm. Patient comes with a visual disturbance, left side supracranial carotid aneurysm. Now, I have already performed the high flow bypass between ECA and M2 segment. Now, I tentatively trap the aneurysm and I open the radial graft like this. But MC pressure monitoring did not recover. The MC pressure, mean pressure 35. This is too low. The systemic mean pressure was 80 at this moment. So something happened, something wrong. So I put a clip on the anastomosis at the ECA and pull out the radial artery and confirm the backflow from the M2. Backflow was very good. So I have a doubt of the injury of something intima of the radial artery at this moment. So I opened the radial artery and I asked my assistant to take the saphenous vein graft from thigh. And radial artery, I opened and checked. The proximal part of the radial artery has an injury of the intima, like this. So at this moment, I think this may causes something trouble of the graft blood flow. So this is a new saphenous vein graft, and here is this radial artery. This radial artery looks good, so I did end-to-end anastomosis of radial artery and saphenous vein graft with Fishmore streaming like this. And from proximal of the saphenous vein graft, I expanded the graft, saphenous vein, and the radial artery hybrid graft. And the proximal saphenous end is anastomosis. It's anastomosis on the external carotid, like this. Looks good. So put the temporary clip on a cervical carotid and open the saphenous vein and the radial artery hybrid bypass. Now, MC pressure is recovered well than the first bypass. But you can see the mean pressure of the MCA is 32. The systemic pressure is 60. But the transit time from it looks good at this moment. 280 milliliter per minute. So I confirmed the bypass worked well. So I directly punctured the aneurysm and slapped the aneurysm and trapped the aneurysm to decompress the optic nerve. After closing dura, the graft patency was good with the Doppler sign. And no high signal in diffusion image. CT angio shows a good patency of the graft. But 10 hours later, without neurological symptom, MRA shows a bypass occlusion. Patient has no neurological deficit at this moment, but during MC pressure monitoring, with the ICA occlusion, the MC pressure very low, around 30 millimeters. So if I didn't reconstruct the bypass, this patient must have the massive infarction in 12 hours or 24 hours after this event. So I decided to perform the second emergency operation to make the revision of the bypass. This is occluded saphenous vein graft. The thrombus inside the graft is taken out. And this is just above the radial artery M2 bypass. I put a temperature and I confirm the inside of M2. Inside of M2, no thrombus, still patent. So I put a permanent grip on the radial artery graft to reflow the M2 segment. Distal to first radial artery M2 bypass, I anastomose the new saphenous vein graft. This is the new saphenous vein graft, which was placed in submandibular root. What was the cause of the graft occlusion? Later, I can show you. Anyway, now the saphenous vein is anastomosed to a distal to a first radial artery M2 anastomosis. And this is the proximal saphenous. And I am detwisting of the graft. And this is a trimming, Fishman's trimming of the proximal saphenous vein graft. You can see here is an internal carotid proximal, because already internal carotid artery is occluded in a supracranial carotid. So the ICA can be used as a donor. Anyway, at this moment, I open the graft, and the graft pulsation is very good, and the filling of the brain surface is very fast. This was completely different from first graft surgery. The transit time from it shows around 270 milliliter per minute blood flow. And fortunately, nothing happened in a diffusion image, and the CT angio shows a good patency after surgery. 1 day later, 2 weeks later, the graft is patent. So, what was the cause of the graft occlusion? The CT angio immediately after surgery shows like this, left side. This patient had an elongated, very long styloid process. Unfortunately, I put the graft medial to a styloid process, medial to a digastric muscle, medial to a stylohyoid ligament. This was a cause to kink the graft. So immediately after surgery, graft was patent. But 12 hours, 10 hours later, graft was occluded because of a kinking of heel. After this event, I learned in a submandibular root, placing the regardless radial artery or saphenous vein graft, we should put the graft between digastric muscle and the mandibular, or between stylohyoid muscle and mandibular. To do this, graft must be placed lateral to a digastric muscle. So, in the second surgery, I put my finger lateral to a digastric muscle, lateral to a styloid process. I confirmed it. Then I could introduce the graft lateral to a digastric muscle between digastric and mandible. So the proximal cause of a graft is totally different from first surgery. You can see it. First surgery, the graft is kinking like this. Very long medial course, very big medial course. But the second surgery, the graft anastomosis at the cervical carotid, and it is coming straight up, almost parallel to mandibular, then coming up to the head. This is a very important. So the appropriate, correct graft route is like this: lateral to digastric muscle, medial to mandibular. Actually, medial to mandibular, medial pterygoid muscle is attaching. So from the cranium through the temporal muscle, lateral to lateral pterygoid muscle, between lateral pterygoid muscle and the temporal muscle, you can put the carry from the cranium to the neck, and the carry can penetrate the medial pterygoid muscle, and you can feel the tip of carry through the neck, lateral to a digastric muscle. Then you can place the graft penetrating medial pterygoid muscle, lateral to a digastric muscle, lateral to a stylohyoid muscle, lateral to a styloid process. This is important anatomy to perform the high flow bypass. I think it's almost time to finish. So I can conclude my presentation. Clean and bright operative field is necessary to perform the accurate surgery. To do this, hemostasis in every step, in skin incision, skin elevation, muscular elevation, muscular incising, craniotomy, after craniotomy, from a bone cutting edge, from epidural space, oozing, venous oozing, middle meningeal artery bleeding, everything must be stopped. We have to run the appropriate way of hemostasis, coagulation, put the gel form, put the Sargicel, put the fibrin-soaked gel form or Sargicel to get the hemostasis. We have to use the appropriate hemostasis. And in a subdural space to perform the cisternal approach like a transribian, we need the highest magnification to see tiny structures like arachnoid trabecula, tiny veins, tiny perforators. We can cut only arachnoid membrane. No vessel can be cut. Not only arteries, but veins must be preserved. Distal ribbon separation between frontal and temporal lobe is a basis of a microsurgery, especially of microanastomosis. Training of bloodless atraumatic separation of distal transribbon fissure is a good training to achieve the skill to control your physiological tremor during micro manipulation, especially to do a microanastomosis. And watertight dural closure. Dural closure is necessary in every surgery. Everybody, especially young guys, the dural closure performs every day when you perform the craniotomy. Watertight dural closure is a good training to perform the microanastomosis. So, daily work is a good training for accurate neurosurgery. That's it. Thank you very much.
Thank you, Professor Tanikawa. We have time if you like to continue with other approaches like interhemispheric. We have time if you like to continue your presentation if you want.
Okay.
It's open. The time is open for you.
Okay. So I'll show you the additional approaches about the anterior interhemispheric approach and PCA aneurysms. Anterior interhemispheric approach is a very useful and very strong approach, but it's not popular to do because this is a relatively difficult approach. To separate the interhemispheric fissure is not easy because the biggest reason why is indentation of bilateral cingulate genesis. And the pia mater of the cingulate genesis is very weak, and during separation of interhemispheric fissure, the pia injury easily happens. So everybody has a difficulty to separate the interhemispheric fissure at first. Even me, around 30 years ago, when I began the interhemispheric approach, it was so hard work. But if we continue the training, even the difficult interhemispheric approach can be performed safely. And this is a very useful approach, especially for supra-projecting or posterior-projecting ACOM aneurysm, because through the arterial approach, the supra-projecting or posterior-projecting aneurysm is very, very difficult. Even if you perform the gyrus rectus sucking, to see the behind the aneurysm projecting superior or posterior, to confirm the behind the aneurysm is very difficult. So in such case, interhemispheric approach is very, very good to confirm the older anatomy of ACOM complex. And if you have something trouble during neck clipping or dissecting aneurysm, you can perform the revascularization like A3 side-to-side anastomosis immediately, because the A2 segment or A3 segment at the corpus callosum genu has already been exposed during the interhemispheric approach. The biggest drawback is frontal sinus is often opened. Appropriate management, appropriate repairing of the frontal sinus is necessary to avoid the postoperative infection. Anyway, I'll show you an exact example of the large ACOM aneurysm. This is a large ACOM, unruptured one, 72-year-old female. With the interhemispheric approach, this is the left side A1 and A2 securing. In this case, I thought either A2 cannot be preserved because of very severe adhesion of A2 segment. So I put a temporary clip after A3 anastomosis on the left side. And this is the direct dome puncture to decompress the aneurysm. Then you can secure the right A1 and A2. You can see here, very thin neck at the right A2 proximal between the neck. So I repaired the very thin neck with a direct stitching. And I put the clips like this. Fortunately, both A2 could be preserved. But you can see during dissection of right A2 here, I stitched A2 directly, and immediately after CT scan, this part is patent, but 1 week later, here was occluded. So A3 bypass worked well as an insurance. Patient had no neurological deficit. Next case is a 64-year-old female, recurrent A1 fusiform aneurysm. This patient had a neck clipping through the right perineal plate on the ruptured ACOM aneurysm. After ruptured ACOM aneurysm, patient had unruptured fusiform A1 distal aneurysm. In this case, the left side A1 was aplastic, so I decided to perform the jump bypass between A1 proximal to right A2. Because in this case, right A1 must be trapped. So this is N2 side anastomosis using a radial artery graft on the right A2. Then the proximal end of the radial artery graft is placed under the tip of a frontal lobe. In a first surgery, the olfactory nerve has already sacrificed, so it was easy to place a radial artery graft under the frontal tip. And here is the A1, and the A1 radial artery anastomosis is performed, and a radial artery graft is opened. Now, the bypass between A1 to A2 is opened, and I am trapping the fusiform aneurysm. The previous ACOM clip is removed, and I am confirming the previous clip on the fusiform aneurysm. This is distal to the aneurysm, distal A1. The aneurysm is completely trapped, and the ICG angio shows a good feeling of the bypass, and the distal ACA territory bilaterally filled through the radial artery graft. And now the aneurysm is trapped and taken out for pathological study. This is the final view. And the CT angio shows a good reconstruction of right A1 to right A2, and ACOM is taken. Aneurysm is trapped. This is a vascular reconstruction for ACA territory. The surgical strategy for complex aneurysm surgery is published on World Neurosurgery by my colleague, Dr. Ota, in 2016. You can see it. I'll show you a PCA aneurysm. PCA aneurysm is rare and it is unusual. You can see this is a right side fusiform, partially thrombosed P2, P3 aneurysm. This is a left side down, park bench position, right posterior interhemispheral approach. Now, this is the right calcarine artery distal to the aneurysm. The occipital artery is harvested, and this is the occipital artery, calcarine artery, N2 side anastomosis to secure the blood flow to trap the aneurysm to calcarine artery. This is the proximal part of the calcarine artery, and I am secured the proximal PCA, and this is another branch arising from the aneurysm, small branch, and this is a proximal PCA, P2P. This is a P2P, and this is another small branch. The small branch arising from the aneurysm is anastomosed to P2P, and it is well reconstructed. And inside the aneurysm, thrombus is taken out and completely trapped. So the calcaneal artery is secured by occipital artery calcaneal bypass, and the parietal occipital artery is reconstructed by a direct anastomosis to proximal PCA. This is a CT angio, and the patient recovered well, nothing happened. Another case, this is a 58-year-old man, Taiwanese, very big thrombus giant aneurysm. Patient have a hemiparesis because of a compression of a basal ganglia due to the thrombus PCA aneurysm. This is a STA, posterior temporal artery arising from P2P. After partial temporal lobectomy, I could expose the aneurysm and I could confirm the P2A proximal to the aneurysm. I am incising the aneurysm to decompress by thrombectomy inside the aneurysm. Very thick old thrombus inside. Gradually along taking the outer thrombus, gradually aneurysm can be softened, and I could confirm the neck like this. So I could put the clip as a neck clipping. At this moment, this is a coil previously placed inside the aneurysm, and this is the orifice after removal of the coil. Almost thrombus the aneurysm, coil does not work. Anyway, the aneurysm well decompressed, basal ganglia well decompressed, patient recovered well. Before surgery, patient couldn't walk, but after surgery, with rehabilitation, patient recovered well. 1 year later, patient walked to my outpatient clinic, recovered well. So the patient recovered from modified Rankin scale 2 to Rankin scale 1. So this is end of my lecture. Thank you very much.
Thank you very much. So we can now open the panel for discussion.
May I have a question, Dr. Tamer?
Yes, please, Dr. Omar.
First of all, I would to thank Professor Taya for this very excellent and distinguished experience and excellent work. Thank you very much, Professor Tanikawa. My questions, what is the criteria for you to choose between microscopic surgical clipping or to do endovascular for cases with aneurysm? Thanks.
Basically, we perform the clipping first. We think the clipping first. But in some cases, like lower basilar or mid-basilar trunk aneurysm, in such case, we choose the endovascular treatment. Of course, the big discussion with the patient and the patient family, because technically, it's not impossible to put the clip to a mid-basilar, lower basilar aneurysm, or a very distal vertebral, intradural vertebral aneurysm. Technically, clipping is possible, but to do this, the very invasive approach is necessary, like posterior petrosectomy and anterior petrosectomy, like a combined petrosectomy. So, especially in unruptured asymptomatic basilar trunk aneurysm, such approach is too invasive. So we have a discussion with the patient and the patient family, and compared to neck clipping, the endovascular coiling is less invasive, but recurrent rate is relatively higher than neck clipping. Everything is we explain everything, our surgical result and the endovascular result, and a patient can choose which one is appropriate for him or for her. So except lower basilar or mid basilar aneurysm, we recommend the surgical neck clipping at first, as a first choice. But of course, we have a discussion with patient and the patient family. But many of patients who were referred to my hospital strongly wishes open surgery because they know our result.
Yeah. We can see that very clear. Okay, there is a question. There is a question about from Dr. Muhammad Farouk. He's asking about what did you make in the patient with M1 giant aneurysm, and then you did a double barrel bypass, and then after you did the bypass, you remove the aneurysm and resuture the M1 again. What make you think you can do that, or what's the point in doing this? You could only stop at the double barrel. So what's the point or the protocol about this?
Yeah, it's a good question. Normally, if you perform the double barrel bypass, just put the clip proximal to the aneurysm is good enough. Yes, basically it's good enough. But we have a bad experience of the delayed occlusion of lenticular striate arteries. Because in that case as well, the lateral lenticular striate artery was arising from a distal M1, distal to the aneurysm. And a double barrel bypass can perfuse such the perforator, but by the intra-aneurysmal thrombosis after proximal occlusion, sometimes, occasionally, such a thrombosis can be a cause of thrombotic occlusion of such a perforators, delayed occlusion of perforators. And the stamp occlusion of a proximal M1, it may causes a delayed occlusion of a medial lenticular striate artery or something perforators. To avoid this, the anterograde flow in M1 segment is necessary. So this is the reason why I perform the M1 end-to-end anastomosis after trapping resection of aneurysm.
Okay.
To avoid,
delayed occlusion of the perforators.
Yeah, to avoid the occlusion of perforators.
Exactly. Okay.
Yeah.
There's another question from Dr. Abdullah Zidan. He's asking about how do you choose or decide which segment of the middle cerebral artery you will put the bypass? If you put in a large M1 or M2, how many hours you need to do the bypass? How much time you need how much time you need to do a bypass in a big trunk of the M1, with the middle cerebral?
M2.
Yes.
Usually we need 15 to 20 minutes.
Okay. And which artery you choose? Which part of the vessel you choose preferably?
Usually we use M2 segment.
M2
But
segment.
depends on the patient arterial condition. If patient has a very hard atherosclerotic change on M2 segment, we can choose M3 or M4 segment. I want to avoid the very thick atherosclerotic plaque.
Okay.
So depends on the condition. But the M2 segment is appropriate to perform the STA MCA bypass.
Okay, and how much time you think it's it's the critical time to do the bypass if you include one of the M2s? For example, can we include for half an hour or 45 minutes, or it's not allowed?
In my experience, less than 30 minutes is safe.
Okay.
But more than
another
30 minutes.
Okay.
Sorry? More than 30 minutes, something happened. More than 40 minutes, the limited part of infarction happened. More than 15 minutes, 1 hour, terrible. So we need enough training before performing the bypass. I always tell my young guys to achieve the skill to perform the 1 minute for one stitch, for 1 minute for one stitch. So if you perform the 20 stitches, you can finish the 20 stitches in 20 minutes. This is I always tell my young guys to have a training every day.
Perfect.
Like this. Yeah.
Okay. I don't think. What do you think is better, high flow bypass using radial artery or saphenous vein graft? Which do you prefer to use, radial artery or saphenous vein graft?
Yeah, I prefer radial artery, but there are some patients, especially elderly lady patient, has a relatively very small radial artery. Our minimal smallest record of radial artery was 2.3 millimeter. It is almost same size with the STA. So in such case, the radial artery cannot work as a high flow bypass. So I think that to perform the high flow bypass, we need a sufficient size of graft. So in such case, we should choose a saphenous.
Okay. So I have a last question. In your experience, of course, you operate many patients from Japan, from other institutes. Which is better for the aneurysm in the redo surgery, coiling or clipping? So which has a higher rate of redo surgery, recurrence, in the coiling or in the clipping series in Japan?
You mean the recurrent surgery after clipping or endovascular?
Yes, exactly.
As recently, after coiling is much than after clipping. Gradually get increasing.
Okay.
But both is difficult.
Okay, so no more questions, and I would like to thank you very much.
I have question, Dr.
Okay.
please.
Free.
Yes, Professor Tanikawa. My question is in the form of a teaching purpose. You know, there is some departments all over the world insisted only on surgical vascular clipping without doing endovascular, and other departments insisted only on endovascular alone without any trial of surgical intervention. What do your recommendation and what your opinion from your experience at Japan? How could you establish a good department for vascular neurosurgery, either microscopic and or endovascular? how we could teach our juniors and how we could build a protocol for that from your experience of point. Thanks.
I couldn't catch up. What do you
So
mean?
Dr. Omar said in some departments insist on clipping, other departments insist on coiling. So what is the protocol you think it's good for the patients, in your opinion?
Yeah, it's a difficult question, but I overthink for example, I showed you clipping of a basilar top, distal basilar aneurysm, but nowadays the basilar aneurysm, distal basilar aneurysm is treated by endovascular treatment. This is the common sense nowadays. But because the clipping to a distal basilar aneurysm is difficult, and the surgical results normally not good. This is the biggest reason why the majority of neurosurgeons recommend endovascular treatment. But this kind of issue, especially the issue which depends on the skill of the surgery or of the endovascular treatment, depends on the surgeon. The skill is different. Each surgeon has different skills, different levels. So depends on the neurosurgeon. If the neurosurgeon can do a neck clipping or distal basilar aneurysm safely, he can recommend the clipping. But he can't. If he can't, he must recommend the endovascular surgery to the patient. So depends on the achieved skill level. The recommendation is different. Actually, so this is a difficult issue. I think it's difficult to generalize.
Thank you very much.
Thank you.
So any more questions or comments, Dr. Nasser?
Thank you, Tamer, very much for this great session.
Thank
I
you.
would like to thank Professor Tanikawa for accepting our invitation. It was a great honor to be our guest in this webinar. I would like to thank all participants. It's time to close the session. Next Friday, webinar number 6, our guest speaker will be Professor Basant Misra, Professor Osama El-Ghannam, and the moderator will be Professor Amr Samman. Next Friday, it will be from 2 to 4 p.m. Thank you for all participants. Thanks to Eva Pharma. Thanks to everybody. Goodbye.
Thank you very much. Thank you, Professor Tanikawa.
Thank you very much.
Thank you very much. Thank you.
Thank you, Professor. Thank you.